So, good afternoon, good evening rather, everybody. We are starting the session, and this session is about question and answer. This is a question and answer session. Right now, we are not taking a class. The class has been already taken with our registered candidates, and this is the question and answer session for our registered candidates. We are having an internal WhatsApp group where our registered candidates are posting questions, and we will be discussing these questions today. Please be specific that this is not a training course right now, but a question and answer session for our candidates who are registered for different server-based courses. So now I will display the list of the questions which has been posted by our candidates. And if anybody wants to post any question now, that will be, of course, giving a secondary preference because we are having a list of already posted questions, but we will give a secondary preference for those who wants to post the question now. You can post the question in the comment box, or you can raise the hand, not this physical hand. There is an option in Zoom to raise the hand where you are having 3 dots. By the option of more, you will get a hands-on option. And on raising the hand, what we will do, we will unmute your system. But please be specific. There should be no background noise from your side if you are raising the hand. So if I have any live questions right now, please raise your hands. And meanwhile, I'm displaying the questions for today, which have been already posted by our candidates. Now, first question by Dr. Yovika Yadav is that how to confirm the renal agenesis. How to confirm the renal agenesis, and she wants to show me some images of renal agenesis also. Point number second, not point. The question number second is that please show some videos of AV malformation to clear normal and abnormal endometrial blood. Now, second question by Dr. Varita Singh is that how to diagnose a schizencephaly, lesioncephaly, and porencephaly arachnoid cyst on ultrasound. Dr. Saida Halima is posting how to diagnose a GTD on ultrasound, how to differentiate GTD from AVM, and what if both exist simultaneously, how to diagnose the condition. Dr. Nidhi is posting what can be the maximum diameter of the fetal gut normally, or at what diameter of the fetal gut do we expect distal gut agenesis. And the next question is how to measure the cervical length. These are the copy-pasted questions. When I say copy-pasted, I mean that as we got the questions, we copied and pasted it over here. So the language is original as it was. So Dr. Komila Singh from Dubai, she is also a registered candidate. I am not able to take measurements and then calculate it. So these are the questions which have been posted by our registered candidates, which we will take today. Now, first question about the renal agenesis. In fetal renal agenesis, what you have to keep in your mind that, first of all, there will be no kidney. So if it is bilateral renal agenesis on both sides, you will not see a renal vessel from this aorta or from inferior vena cava going towards the right or toward the left side, whatever the side kidney is absent. And on ultrasound itself, on grayscale, you will not find kidney. Very simple. But one thing, what I will say that the adrenals are prominent. Try to understand this point. This is a very important point when you are talking of renal agenesis. The adrenals are very prominent as compared to adults. In fetal life, the adrenals are very prominent. So sometimes you may cut through the adrenal. Now see, this is the adrenal gland over here, which will look like a small kidney. So here, keep in your mind that adrenals don't, take this adrenal gland for a kidney. So the next point is that please be specific that you are not cutting an adrenal for a kidney. So now the next question about the AV malformation. First of all, I'm repeating, this is a question and answer session. We are not right now taking any course over here. Now, those who are not registered with us and are watching this video or are online with me, they may not understand because this is merely a question and answer session only. Now, AV malformation. When I say AV malformation, what is meant by AV malformation? AV malformation is characterized by the just hold on. Please don't draw on the screen. Now, when I say AV malformation, these are characterized by an abnormal mesh of vessels, allowing the arteriovenous shunting. This is direct arteriovenous communication without any intervening capillary bed. Now, uterine AV malformation results from the formation of the multiple arteriovenous fistula communication within the uterus without any intervening capillaries. Now, on ultrasound, a grayscale sonography. Now, try to understand, the grayscale sonography may not be specific because what I see there, a range of manifestation, including the subtile myometrial inhomogeneous tubular structures within the myometrium. Please be specific. These will be within myometrium only. And on putting a color, sometimes they will look like a cervical mass-like structure, sometimes in endometrium, sometimes they can go up to the endometrium. But the point is that color Doppler will show me the flow in these vessels and typically shows me a low resistance flow. When I say low resistance, I means that the RI should be in the bracket of 0.2 to 0.5. And high velocity flow pattern will be there. So there will be the low resistance and high velocity flow pattern. Now, differential diagnosis. When it comes to the differential diagnosis, the primary differential diagnosis on ultrasound appearance is enhanced endometrial vascularity itself. And if beta SEG is elevated, you have to consider the gestational trophoblastic disease. And you have to consider the retained product of conception also. And in retained product of conception, abnormalities centered on the endometrium rather than in myometrium. So that is what I told you. It will be more in the myometrium. And when I say retained products are more centered on endometrium. So this way, you can differentiate whether I am dealing with south or north. So this is about the second question, AV malformation. Let me clear all this. Now, this is an ultrasound picture. This ultrasound picture is of AV malformation. So on ultrasound, you will see a bunch of capillaries. And these bunch of capillaries are more in myometrium. They are not in endometrium. And whenever I will be taking a resistive index, I mean the flow in these vessels, that will be low resistance. So you can note it down, how much is the resistance. Now, the next question is about the porencephaly. First of all, what is a porencephaly? It is a congenital disorder in which I am seeing the cystic degeneration. So I am seeing this is a result of a cystic degeneration and formation of porencephalic cysts. The term is usually variable among radiologists with its broadest definition being a cleft. So that is a cleft or a cyst within the brain. And most importantly is that it is having a communication. Communication with what? it communicates with ventricular system or subarachnoid spaces. So these porencephalic cysts will be having an communication with the ventricular system and or subarachnoid spaces. Now ultrasound picture. This will be the ultrasound picture of a porencephaly. So this is the cystic space, cystic area rather, in which I am having the intracranial cyst that communicates with the ventricular system or subarachnoid spaces. And these may also be symmetrical, asymmetrical. There may be some asymmetry in ventricles with displacement of midline ventricular echo. So the midline ventricular echo may be displaced, or there can be an asymmetrical ventricles. And most important is that these clefts, these cysts will have a communication with ventricular system. So next question is that about the GTA, gestational trophoblastic neoplasia. In gestational trophoblastic neoplasia, an anechoic space within the mass related to hemorrhage, tissue necrosis, cyst, or vascular spaces, patients with more advanced disease can present with just an enlarged uterus with lobulated heterogeneous contours, or even a pelvic mass that is adjacent, that extends to the adjacent organs, and adjacent organs, in pelvis, what are there. We will not discuss that because that is already in your course. Now, the next question is that what should be the gut diameter to label it as normal or abnormal? Now, see, usually I am seeing some loops, gut loops in fetal ultrasound. The question posted was how much the gut diameter should be to label it as a dilated gut. So the fetal small bowels, first of all, the small bowels rarely exceed 6 millimeters. So if you are having 6 millimeter and more small bowel, that is dilated. And the colon lumen diameter should not exceed 23 millimeters. So the cut is 6 and 23 for small bowel and colon respectively. Now the last question is not last, the second last is that how to measure a cervical length. I request that candidate to complete the gynecological ultrasound, because there are 2 to 3 classes on cervical length measurement, how to take it. I will quickly go through this question. You have to measure from internal to external os. This is the transvaginal scan and this is the transabdominal scan. You have to measure it from internal to external os. But here is the catch. Sometimes the lower uterine segment is having some contractions that will look like a long cervix. Try to understand. If you are having a very long cervix, maybe a 80 millimeters or a 90 millimeters, how much is the cut? We will come to that. But if you are having an unexpectedly very long cervix, there are high chances that you are dealing with a lower uterine contraction. So wait for the lower uterine contraction. If you are having a so-called, in inverted commas, a very long cervix. There, you have to see for the mucus plug. In that very long cervix, that is actually a pseudocervix with the lower uterine segment, the mucus plug will not extend beyond the internal os. So if you see mucus plug, for example, if this is a very long cervix, if you see mucus plug from here to here only, and here I don't have a mucus plug, then you are dealing with the lower uterine segment contractions. So wait for the contractions to see whether I am having mucus plug confined from external to internal os. That only is a true cervix. Then you have to see for the funneling and all these things, which is included in your course. I'm again requesting that candidate to go and complete the gynecological ultrasound. That is why I'm requesting all times to complete the class before posting a question, because maybe it is already over there what is coming in your mind today. Maybe that you have skipped or have not completed the course yet. So anyhow, prior to pregnancy, how much is the length of the cervix? Prior to pregnancy, most women have the cervix which is in between 35 to 55 millimeter in length. Between 16 to 24 weeks, the cervical length is usually between 35 to 48 millimeters. And when you can label as a short cervix, if your cervix, this cervix, whatever you are scanning, is less than 25 millimeters in length, right, before 24 weeks. So you can note down the measurements part from here. Now, the last question is posted by one of our candidate, and she is not getting the measurement button over there, the knob over there. Now she try to understand. Now, when I say knobology, when I am looking for a knob, I have to see what machine I'm using. In my machine, try to understand, in my machine, the measurement knob can be over here, on second row, on the third, in third knob, that will be for measurement. But in your machine, it will not be here, it will be here. You have to search for the measurement knob. How can I see you? Where is measurement knob in your machine? But there will be a cursor over there, or even the measurement will be written over there. This knobology is like your Android phone. When I use this Android phone, so this is from one company. When I use this, I have to search for where is the message icon. I mean the knob over there, the button over there. Where is the Gmail option? But Gmail option has to be there. The message box has to be there. But where that is, I cannot say. Even if I will get a new phone, not this one, a second one, it will take me time to see for these knobs over there. But the basic important point is that you should know that these knobs has to be searched out. What are these knobs? First of all, I would request that candidate to complete the physics and machine settings, because in that physics and machine settings, there is a course, a class rather, of knobology. Please go through that class, and you will get your answers clear. I will very quickly go through this knobology. This is not a class. I'm giving you a short answer. So in knobology, first of all, your knobs, you should know your knobs. Then probe marker. Probe marker is very important. You now know what side the probe marker should be, and in each and every knob there is a probe marker. Then clear your screen orientation. I will not take screen orientation right now, because on screen orientation, I am having 2 classes on server. So clear your screen orientation. I am just giving you points for now, what you have to go and what you have to keep in mind when you are going through the classes. Clear your screen orientation. And very, very important, this screen orientation is, because without this, you will never ever interpret a picture. Then choose your probe. Not always one probe is superior, not always. For example, this TDS probe is superior, so know your probe and see what probe you have to use. Sometimes the transabdominal is superior to the transvaginal. Now this will take time. Why? Because this is already in your courses. So please choose your probe. Not always one probe is superior to all probes always. Then there are some multifunctional knobs. try to understand, there are some multifunctional knobs. In these multifunctional knobs, the company is not providing you what for this knob is, but the machine display will show you what for this knob is used, because the function of this knob will change as you move from a grayscale to color Doppler, or from color Doppler to power Doppler, or from power to pulse. And what this knob is for this particular point of time, I will be having a display on the screen, and this display will keep on changing depending on what mode I am. So keep an eye on these multifunctional knobs, and the monitor will tell you what for this knob is for this particular point of time. Then choose an appropriate preset. Don't go for a wrong preset. You know now the limitations of a wrong good preset, and choosing a wrong preset will not give you the measurement. Maybe that doctor whosoever is has posted the question is in a wrong preset. That is why she is not getting the measurement option. So use an appropriate preset. For example, if you are in a preset of abdominal preset, why machine will show you a CRL? Why machine will show you a BPD measurement? So by pressing onto that, by choosing an appropriate preset, you are telling machine that I am going to scan this patient. When I say this patient, for example, an early pregnancy scan, then only machine will give you an option to measure a CRL. Okay, so use an appropriate preset. Then the frequency, very important is the frequency. You know that the frequency is very important because it will determine how much the beam will penetrate, and this will define the overall resolution of the machine. By increase in the frequency, your penetration is dropping, and all these things which is there in our server-based courses. Then set the gain. Then there are some TGCs. What is TGC? TGC is also a gain, but a gain for a specific area. Then make use of that TGC depending on whether you want to, decrease or increase. I mean, the gain of the topmost area or the bottommost part of the screen. Then scan with an appropriate depth. There are two classes on depth on our server. The point here, important point, is that you should scan with an appropriate depth, because if you decrease, whenever you decrease the depth, with decrease in the depth, you are increasing the frame rate, and with increase in the frame rate, the things will be more clear, because the resolution of any video is depending on the frame rate. So keep on make an attempt to increase the frame rate, and the first attempt is that decrease the depth. By decreasing the depth, the frame rate is increasing, and by increasing the frame rate, you are having a good quality image. So the point here is that we will not then focal zones, focal points. You have to set these focal, then keep an eye on the frame rate. There is always a box over here. Now see, there is always a display box over here which will tell you what frequency, what depth you are scanning with, what is the frame rate. Keep an eye on that box, and I again request all those candidates who have not completed the physics and machine settings to complete the physics and machine settings. Maybe that you will be needed to revise. The beauty of our server is that you can even revise the classes as many times as you want. So Zoom, of course, is the last option. This thing, I'm again repeating, I'm not right now taking a class, but a question and answer session. So a detailed, a lengthy answer to that small one-word question is that you have to complete your physics and machine settings via our server. So this is all about today's class, not actually class, the question and answer session. So I hope that I have replied to all questions, and I again requesting everybody to complete the topic Complete the topic first before posing a question, and even after completing, if you are having any question, you are more than welcome to post your questions for our interactive sessions on our helpline number, which we are these online interactive sessions we are taking at regular intervals. So thank you very much, and in case anybody is having any question, they can come forward right now. Okay, Dr. Pramod.
Sir.
Yeah, please repeat your question.
How to identify the ureterovesical junction?
UV junction. Okay, for which course you are registered?
In abdominal ultrasound, sir.
Abdominal ultrasound. Tell me honestly, have you completed your abdominal ultrasound course?
I am just undertaking that.
You are undergoing. Have you completed the KUB classes?
Yes, sir.
Completed.
Yeah.
Yeah. Now, in our server-based KUB classes, there are some practical classes where we are showing you how to see for a UV junction calculus.
UV junction calculus, yes, sir. That is a
yes.
twinkle sign.
Right. Now you tell me from whatever knowledge you have gained from those server-based courses, how we can identify a UV junction. Think. I can reply in 2 lines. I don't want to conclude. I want to discuss with you. Can you see? Can you see? Now I am counter questioning you. Can you see a UV junction in a patient without a calculus? Can you precisely say that this point is the UV junction?
That I am not able to see, sir.
You will not be. Because the calculus, there is no pinpoint. I cannot, point it that this is the UV junction. But if there is a calculus, then I can say, because this UV junction is not seen routinely, normally, I cannot see a UV junction unless and until it is dilated.
Okay,
and
sir.
If it is dilated, the first point is there any calculus? And if there is any calculus that will make it dilate, then I can say that this is the UV junction. Where will be the UV junction? UV junction will be at border of the ureter, where the ureter is ending and our bladder is starting. Right?
Sir.
Now, if there is a very small calculus, you told me that twinkle artifact you have learned. If there is a very small calculus, in a very small calculus, the ureter may not be dilated.
Sir.
Then you have to put a color box to see for that ureteric, twinkle artifact. And you have to trace, you can trace from that twinkle artifact up to the small calculus. Now, how to trace the ureter? There is a complete class for that. But the most important thing is that you have to trace it from the kidney, or from the bladder. From midway, you cannot. And if you are losing it, when you are tracing, if you are losing it, go back to kidney, trace it again. And if you lose it, go back to kidney. So this way only you can pick your ureteric calculuses, and you can say whether it is at UV junction or pervo-ureteric junction or somewhere in the mid-ureter.
Sorry, while tracing the ureter, is it convenient to trace it from the posterior aspect? Or
now see, it depends. When I say it depends, what I mean, it depends. Mostly you will get these ureters not from the back, I mean the coronal approach. But if patient is very obese, he is having a lot of fat from the anterior approach, then you can trace it from the coronal approach. But first line, take a scan from the anterior side, and if patient is obese, then only go for the posterior approach. Anything else?
Thank you, sir.
Okay, welcome. If there is any more raise hands, please raise your hand if you have any question. Now I am having one question in chat box. Let me open the chat box. There was a question. Adherent placenta. Now adherent placenta. Now see, this is not a question. When I say adherent placenta, I have to exclude whether I am dealing with placenta accreta. Now, placenta accreta will take 1 hour. And in our server-based courses, we are having 3, if not 4 classes on placenta accreta. When I say adherent placenta, I have to see whether I am dealing with a placenta accreta. And in placenta accreta, there are some criteria which should be fitted to label it as placenta accreta. If anybody can tell me the 5 ultrasound criteria of placenta accreta, please raise your hand. Now, hurry up, hurry up. So to conclude, we will give a quick revision of placenta accreta about these 5 criteria. Please raise your hand. Anybody? Dr. Pramod Kumar has raised the hand. I'm sending an invitation to Dr. Pramod. Yeah, Dr. Pramod.
Sir, uteroplacental junction demarcation will be lost, and so many legs in placenta. Placenta legs will be there, and
okay, Dr. P. Yadav. I'm sending you an invitation because you have raised the hand. Quickly accept. Dr. P. Yadav. Accept the invitation. Anybody else wants to raise the hand? Dr. P. Yadav. Okay. Dr.
Hello.
Yadav.
Yes, sir.
5 ultrasound criteria of placenta accreta.
Sir, number 1, there must be a history of any
ultrasound criteria.
Sir, ultrasound criteria, there is demarcation of uterine and
have you completed your OBS course?
Yes.
Yeah.
There is placental legs.
First of all, low implantation.
G.
Okay. First is the low implantation. Second is myometrial thinning. Okay. G. Then interrupted
serosa.
Yes, interrupted serosa. G. Number 4.
Placental legs.
Very good. Placental legs, moth-eaten appearance of placenta. This is the first point which will catch my eyes, that maybe yes, that I'm dealing with a placenta accreta. And lastly, 5th one.
Lastly, on color Doppler, we can see chaotic flow.
Very good. Very good, Dr. P. Yadav. Thank you very much. So these are the 5 ultrasound criteria of placenta accreta. So thank you very much. God bless all of you. If you will be having any question during our online server-based courses, our online are server-based. You know the difference between the online and the server-based is that the server-based can be started, can be revised, can be completed as per your comfort zone. Whereas the in online classes, you have to be particular time you have to be online, and this is the difference between our online and server-based. We are having server-based, not completely online. And whenever you are having any question, you all are added in our WhatsApp groups. You can post your questions so that your question will be taken in our interactive sessions. So, see you very soon in our next interactive session. God bless all of you. Thank you very much.